If monsoon comes, can malaria be far behind? So today in Academics in Nutshell, we will discuss management of malaria. The commonest being uncomplicated Plasmodium vivax malaria, where the drug of choice is chloroquine. Still, chloroquine resistance against Plasmodium vivax is not common in India. So the total dose is 25 milligram per kg. It has to be divided as 10 milligram per kg stat followed by 10 milligram per kg at 24 and 5 milligram per kg at 48 hours. As an alternative, 10 milligram may be given stat followed by 5 at 6, 24 and 48 hours. Primaquine has to be given 0.25 milligram per kg once daily for 14 days to prevent relapse. Uncomplicated falciparum malaria has to be treated by artemisinin combination therapy or ACT. The regime differs in different parts of India as per the resistance pattern. So in Northeast India, the combination is artemether lumefantrine 20 plus 120 milligram. It's a 6-dose oral regime given twice daily for 3 days. And the number of tablet depends on the body weight of the person. The timing is 0, 8, 24, 36, 48 and 60 hours. For the rest of India, it's oral artesunate at 4 mg per kg body weight once daily for 3 days. And on day 1, a single dose of SP, that is sulfadoxine 25 mg per kg and pyrimethamine 1.25 mg per kg. Here primaquine is given single dose 0.75 mg per kg for gametocytocidal action. If it's a severe and complicated malaria, which is usually due to Plasmodium falciparum, rarely Plasmodium vivax, the drug of choice is IV artesunate. Here the dose of artesunate varies as per the body weight of the child. Children weighing above 20 kg, it's 2.4 milligram per kg, and children less than 20 kg is 3 milligram per kg IV stat, then at 12 and 24 hours, then once daily. Now, if parenteral antimalarials are started, then minimum 24 hours it has to be continued irrespective of the patient's ability to swallow oral medication. But once the child stabilizes, then we have to complete the treatment by ACT, where either artemether lumefantrine combination or artesunate sulfadoxine pyrimethamine as per the resistance pattern and the area of residence. Now, when we deal with complicated malaria in children, we have to remember the specific complications that may be seen in children suffering from severe malaria. The specific complications that one might encounter are cerebral malaria, severe anemia, respiratory distress, particularly acidosis, and hypoglycemia. The renal failure and other are less common in children, which is more common in adults. So we have to be careful of this complication and monitor the child suffering from severe malaria. Regarding chemoprophylaxis, according to National Vector-Borne Disease Control Program, for a short-term stay up to 6 weeks, it's doxycycline 100 mg OD for adults and 1.5 mg per kg OD for children has to be started 2 days before and continued 4 weeks after leaving the malarious area. And for long term, that's more than 6 weeks stay, it's the only adult recommendation which is available, that's mefloquine 250 mg weekly, again 2 days before and continue 4 weeks after leaving the malarious area. So let us fight malaria and let us stop malaria.